Hello guys, I Dr. Virendra welcome you at your YouTube channel of medical student. So guys, today we will discuss about a very important topic. This is perinatal asphyxia or birth asphyxia in the newborn. So guys, our objective is introduction, definition of the birth asphyxia, etiology, pathophysiology, clinical manifestation of this, Sarnat Sarnath staging of the HIE, management of the perinatal asphyxia, newer mode of the therapy of the perinatal asphyxia or prognosis of the asphyxia. So guys, perinatal asphyxia is the major cause of neonatal and under 5 mortality, particularly in the developing countries, and it accounts for 9.4% of the total under 5 child mortality worldwide. And along with the prematurity and systemic infection, perinatal asphyxia is one of the 3 most common cause of neonatal deaths. And WHO defined the perinatal asphyxia as failure to initiate and sustain breathing, while the Neonatal Forum National Neonatal and Perinatal Database Network defined the perinatal asphyxia or birth asphyxia as moderate perinatal asphyxia where the slow or gasping breathing or an APGAR score is 4 to 6 at 1 minute, while the severe perinatal asphyxia is if there is no breathing or an APGAR score of 0 to 3 at 1 minute of the age. And American Academy of Pediatrics and ACOG guideline given some essential criteria for the perinatal asphyxia, which is profound metabolic acidemia as the pH is less than 7 in the umbilical cord blood, and if there is persistence of the APGAR score less than 3 for more than 5 minutes, and if there is sign of neonatal neurological dysfunction as seizures, encephalopathy, tone abnormalities, and evidence of the multiple organ involvement as the kidney, lung, liver, heart, and intestines. This is the APGAR score having the 5 point, which is the appearance of the skin, heartbeat or pulse, G for grimace, A for activity, and R for the respiration. Where the APGAR score having the 0, 1, and 2 points for the each points, and maximum score is the 10 and lowest score is the 0, with the appearance of the skin if the pink is the score is the 2, if the extremities is the blue and central is the pink, is the score is the 1, and if the all newborn is the blue, that the score is 0. If the heart rate is more than 100, score is 2, less than 100, score is 1, no heart rate is the 0, and grimace having the child is cries or pulls to the away, score is the 2, and big cries there, the score is 1, and no response to the stimulation is the score is the 0. If the child is very active at the movement, which is score is 2, and if the arm and legs are flexed, this the score is 1, and if the child is flaccid or there is no movement, is the score is 0. And if the respiratory having strong cry or good breath, is the score is 2, and the slow irregular breathing is the score 1, and no respiration is the score is 0. So guys, there are multiple etiologies of the perinatal asphyxia: antepartum, intrapartum, and postpartum. Whereas the antepartum and postpartum causes are more than 90%, which is due to the placental insufficiency, while the postpartum causes are around 10%, which is due to the pulmonary, cardiovascular, or neurological insufficiency of the children. And placental causes are as if there is decreased maternal oxygenation due to the any anemia, pulmonary or cardiac or neurological disease in the mother may causes decreased oxygen saturation, or if the decreased blood flow mother to the placenta is due to the maternal infection due to the shock, dehydration, or hypotension, or it lead to the decreased blood flow placental to the fetus, which may be due to the placental abruption, true knot, cord prolapse, or cord compression may be causes. This may lead to the decreased gaseous exchange across the placenta and fetus, which may be due to the maternal hypertension, diabetes, drug abuses, post-maturity, or placental calcification, infarction, or fibrosis may be there, or if there is increased fetal oxygen requirement due to the fetal anemia, intrauterine growth retardation, or fetal infection may causes placental insufficiencies which lead to the hypoxia. And postpartum factors are pulmonary causes as the severe pulmonary distress, cardiovascular causes as the cyanotic congenital heart diseases, central nervous system causes as the intracranial hemorrhages or meningitis, anemia may be due to the severe hemorrhage or hemolytic disease of the newborn, or infection due to the any viremia or bacteremia is the sepsis may causes asphyxia or perinatal asphyxia. The physiology of this asphyxia is decrease or deprived of the oxygen in the newborn, which lead to the rapid breathing, which cause asphyxia is continue. In this situation, respiratory movement ceases and heart rate begins to fall and muscle tone in decrease, which lead to the primary apnea. If the asphyxia continue at this stage, you can see in this graph there the up and down waves are there due to the deep gasping respiration, and heart rate you can see here it is continue begin to fall, and muscle tone and BP is also begins to fall, and muscles is flaccid, which causes gasping, which ultimately lead to the secondary apnea. And guys, physiologically, if the asphyxia is there, initially the shunting of the blood toward the brain, heart, and most vital organ as the adrenal also is done. This is called as the diving seal reflex, and blood is away through the lungs, kidney, and GIT. And in this condition, there is no brain organ injury. And if the asphyxia continue, this shunting of the blood within the brain having the anterior circulation is suffer while the posterior circulation is maintained, which lead to the cerebral cortical lesion. And the near total asphyxia is there due to the cord accidents or maternal cerebral perfusion is arrested, hypoxia is abrupted, or severe hypoxia is there. In this condition, there is no time for the compensation, and in this stage, thalamus brain stem is injured and the cortex is spared. And hypoxia may also lead to the accumulation of the amino acid like the glutamate in the damaged tissues, will lead to the increased amount of the intracellular sodium and calcium, which causes tissue swelling and cerebral edema. And hypoxia and ischemia in term infants may cause cortical atrophy, while in the preterm children there may be periventricular leukomalacia or intraventricular hemorrhages. And hypoxia impair the cerebral oxidative metabolism, which lead to the increased lactate level and pH begins to fall. This is acidosis, which causes ultimately shock or other causes of disease. So guys, there is clinical manifestation of the HIE as there is CNS manifestation as the intracranial hemorrhage, hypoxic ischemic encephalopathy. Serious causes are bradycardia, arrhythmia, hypotension, myocardial ischemia. And in case of the respiratory system, there may be apnea, renal system, there may be acute tubular necrosis, in GIT, there may be necrotizing enterocolitis, in DIC may be there, in metabolically, there may be hypo or hyperglycemia, hypocalcemia is very significant in case of the perinatal asphyxia, and hyponatremia may be there. So guys, there is a important staging done for the HIE staging, that is the Sarnat and Sarnath staging, where the categories is taken as the level of consciousness, muscle tone, posture, DTR or reflexes, myoclonus, sucking reflexes, morose, pupil or seizuring, or duration of the symptoms and outcome of the child, and EEG monitoring. So guys, of the perinatal asphyxia, HIE divided into the three stages as the stage 1, stage 2 and stage 3 as the mild, moderate and severe staging. And this is also mentioned in the Levene classification as the star marking points as the level of consciousness and muscle tone, sucking reflexes or respiration and seizures. If the child is hyper alert or normal muscle tone with the weak sucking reflexes or respiration or seizure if not present, this is the stage 1 or mild HIE. In stage 2, there is child is lethargic with the hypotonic stage and weak or absent respiration or sucking reflexes. or seizure is common in this stage. And stage 3, there is stupor or comatose and child is flaccid with the absent sucking reflexes with the decerebrate posture in case of the seizure may found, and this is very important stage, and this is HI3. So guys, management of a child of the perinatal asphyxia, we having a goal as prevent to the further brain damage and maintain temperature with the airway, breathing and circulation management, correct and maintain the normal metabolic process. If the child immediately cried after birth, routine care to be done by providing the dry bath, dryness, clear the airway if required, initiate the breastfeeding, monitor the breastfeeding, heart rate and color of the child. If the child is not cried just after the birth or having some delayed APGAR score, neonatal resuscitation may be required, for which we had done another video, and transfer the infant to the NICU if the APGAR score is 0 at 1 minute. Prolonged bag and mask ventilation for the 60 seconds or more, or chest compression is done at the neonatal resuscitation. So guys, in the NICU, we should maintain the normal temperature as 36 to 37.5 degrees centigrade and avoid hyperthermia, and maintain normal oxygenation as SpO2 between the 90 to 95% and avoid hypercarbia, and maintain the normal tissue perfusion with the intravenous fluid if required, and if dobutamine or dopamine inotropes can be given, and maintain the normal blood parameters as the blood glucose level 75 to 100 mg per deciliter and hematocrit level at the 45 to 55%, and maintain the pH above more than 7.3 and maintain calcium level as 9 to 11 mg per deciliter. And guys, if child having the seizure, therapeutic phenobarbital can be given at the dose of 20 mg per kilogram of the loading dose with maintenance in the 5 mg per kilogram per day, as lorazepam may also be given. Nutrition to be start as soon as possible when the hemodynamically stable patient, and administer vitamin K 1 mg IM with the all infant. There are some newer modes of the therapy, as the therapeutic hypothermia is only recommended treatment for the perinatal asphyxia at the temperature cap 33 to 34 degrees centigrade in infant of at least 36 weeks of the age with moderate to severe encephalopathy, and initiate within the 4 to 6 hours after the birth, and it should be continued 72 hours of the age, and reduce the motility and neuromorbidity by 18 months of the age, and selectively cooling of the head and whole body cooling can be done by the different methods as the Mira cradle or alternative methods. And another newer modes are the prophylactic phenobarbital can be given at the dose of 40 mg per kilogram administered prophylactically, associated with the better neurodevelopmental outcome at the 3 year of the age. And the drug under the investigation are for the neuroprotections as blockade of the free radicals and scavenging of the oxidants, calcium channel blockers, NMDA receptor blockers, and inflammatory mediators blockers. So guys, there are some special role of the investigation as the EEG can be done for the prognostic factors, and amplitude integrated electroencephalography can be done for the simplified, and can be performed in the continuous basis in the NICU. That following the abnormalities would indicate the prognostic is very poor, where the widening of the fluctuation in the amplitude with the baseline voltage drop line near the 0, and the peak amplitude under the 5 millivolt or seizure spikes is there. And in the ultrasound, cranial ultrasound is not good for detecting the HI in the term babies, while the hypoechoic area can be seen in the very severe cases, and preterm babies may found intraventricular leukomalacia and eye intraventricular hemorrhage. CT scan is more useful in after the traumatic delivery and suspected having the extraaxial hemorrhage, while the MRI is done for the abnormalities of the thalami and basal ganglia in the term infant, and in the preterm infant if there is abnormalities of the white and gray matter. And MRI is preferred over the CT as there is no radiation exposure in the MRI. So guys, there is poor neurodevelopmental outcome predictors are as failure to establish of the respiration by the 5 minutes after birth, or APGAR is 3 or less at the 5 minute, onset of seizure within 12 hours, if there is refractory convulsions, stage 3 HIE, persistent oliguria, and inability to establish the oral fluid by the 1 week, abnormal EEG and failure to normalize by the 7 days of the life, and abnormal CT, MRI or MR spectrography may be found. So guys, outcome of the HIE, a meta-analysis is done where in severe cases of the HIE or HIE third, the risk of death is 61%, while in case of the HIE 1 or mild cases having the less than 1% of the death, while the severe disability is found in severe cases or HIE 3, 72%, in the HIE 2 is the 20%, or in mild cases there is the less than 1% of the disabilities. So guys, this is all about the perinatal asphyxia. So guys, if you did not subscribe our channel, subscribe it, press the bell icon, share it to all your medical students, your friends, to get the benefit, and comments in the comment section, and what do you want in next video. Thank you very much.